Hey everybody, welcome to today's ECG. My name is Reid. Don't forget to download the PDF for today's ECG so that you can follow along and make your own notes, and like and subscribe this video while you're there. Let's jump into this. So the first thing I'm going to do is look at the forest and the trees of the forest for my QRS, excuse me. So what I'll do is I like to pick maybe a lead here at the bottom, a rhythm strip, and I see I've got this wide complex QRS that is pretty regular. My rate here, if I zoom in, this falls on a solid line. My rate is 300, 150, 100, 75, 60 beats per minute on the dot. And when I look throughout, I notice that all of these QRSs are landing right on that solid line. So 60 beats per minute is occurring very regularly. There is no deviation. That's pretty difficult to see. Usually there is some small variations as our vagal tone increases and decreases with respiration. And so what you'll find is why this is occurring is if you look in front of the QRSs, you start to see these little deflections, and these are pacing spikes. And so this person, just by looking at this, when we look at the forest part of our ECG, we see we've got these pacing spikes. And the pacing spikes are right in front of our QRSs, and so these are ventricular pacing spikes, because when you see the spike, what that's telling us is that it's firing off. So some wire is down here in the ventricles. When it shocks the ventricles, that is what gives us this spike here. And then once that spike occurs, we get depolarization across the ventricles, causing this wide complex QRS. So we've got at least a ventricular paced rhythm here at a rate of 60 beats per minute. And so let's see what's going on with the rest of the rhythm here. It's only one of our chambers. So next thing we're going to do is we're going to evaluate for atrial activity. And so I'm going to look in front of these QRSs for P waves, and I'll kind of scan through various leads, and I don't see any P waves before my QRSs. And what I do see is I like to look at V1. V1 gives us good P waves if there are some, nice sharp P waves. I don't see any. I see this baseline fibrillatory wave here. It's not perfectly flat. There are some small, fine upward and downward deflections, and so when the atria is not contracting, but there is this noticeable electrical activity flowing through it, that is indicative of atrial fibrillation, right? And we think of atrial fibrillation, well, it's usually irregular, but in the setting of a ventricular pacemaker, this atrial fibrillation is not going to cause that irregular rhythm. So likely what's going on with this person is this person has AFib, but they also have an AV block. How do I know that just from this ECG? Well, we know that they have a ventricular lead in their ventricles at a minimum. And because of that, usually when AFib is going on, if I look at my heart, we've got these fibrillatory waves that are going throughout the atria, and they're bumping into this AV node, and the AV node can take it and send it down. And then they keep fibrillating around, and then it'll bump in again, and it'll send it down into the ventricles. But in this case, this person has an AV node that appears to not work because none of those fibrillatory waves are making it down. We know they're not making it down because these QRSs are only coming from the paced beats. So because of that, we are unable to measure our PR interval. Our QRS duration, let's take a look at it. We said it was wide. If I measure it, it is greater than 120 milliseconds, which is a wide QRS, which is indicative of what we would see ventricular pacing spikes, because it does, when they do pace the ventricles, it spreads slowly across the ventricles in a cell-to-cell gap junction manner. It doesn't take the His-Purkinje system that we know is what really speeds up the duration of our QRS. Our QT intervals, what I like to do is I like to take an R to R or a QRS to QRS interval here. And what I do is midway on that interval, we should see that the T wave is done by then, and it is. And so we'd say that our QT at this point is good. That's just eyeballing it. You can obviously calculate the corrected QT interval, which You just need to measure the R to R interval in seconds and all that stuff. We're not going to worry about that here. And then the last thing I'm going to do is look for pathological Q waves, which we cannot really do because this is a ventricular paced beat. So Q waves would only be really helpful if it's coming from the AV node. And we can still look for ST and T wave changes. Remember that in order to look for ST and T wave changes in somebody with either a left bundle branch block or ventricular pacing, the ST and T waves are looked at with a new criteria, or a different criteria. It's called the Scarbosa criteria. Because the reason why we use this Scarbosa criteria is because the ST and T wave morphology will change when we are not taking normal conduction within the ventricles, and that occurs in these left bundle branch and ventricular paced beats. And so this Scarbosa criteria, go ahead and check that out. Go take a look at it. I don't have a video on it, but I will in the future. And that'll help you kind of better understand what's going on with the ischemic changes to expect with left bundle branch blocks and ventricular paced rhythms. But I don't see any here, and so let's put it all together. What do we got? We've got an atrial fibrillation with a ventricular pacing at 60 beats per minute. So hope that helps. This is a pretty simple one this week, but it's good and helpful to know, when you have a patient in front of you, what's the point of this ECG? Sometimes it's to just determine, do they have a rhythm that is perfusing? And this person, within the setting of AFib, they still are at risk of having like embolic strokes. So just because they have a pacemaker doesn't mean that they are immune to the consequences of AFib. So I hope this helps, and hope everybody has a great rest of the day. Subscribe if you like these videos, and we'll see you tomorrow.